Thank you for the invitation. I'd like to present a brief review of the radiological findings in complex lymphatic anomalies. I have no disclosures. I'm going to concentrate on these four conditions which have overlapping clinical and imaging features and identify key radiological features that help to differentiate these conditions. Starting off with Gorham-Stout disease. This is probably the most misdiagnosed condition, as a variety of lymphatic disorders of bone have been incorrectly grouped onto this diagnosis. However, this is a disease with very specific clinical and imaging features, the key ones being progressive osteolysis and cortical destruction. Another common finding is the presence of periosseous soft tissue. This can enhance avidly with administration of contrast and may reflect disease activity at that point in time. In terms of distribution, contiguous bones are affected, most commonly in the cervical spine, clavicles, and ribs, and there is relative sparing of the appendicular skeleton. These are frontal and lateral radiographs of the spine in this young male patient, showing almost complete destruction of the posterior elements of the spine on the lateral radiograph, resulting in instability. On MRI, extensive soft tissue disease is seen in the affected region, and the soft tissue disease enhances avidly with administration of contrast. These two images reflect the progressive nature of the disease, with focal areas of osteolysis progressing to almost complete destruction of the femur and the associated acetabulum. This axial CT slice of the cervical spine demonstrates the complete cortical destruction of the T1 vertebral body. The second condition, which is primarily a lymphatic osseous disorder, is generalized lymphatic anomaly. As the name suggests, this is a much more diffuse condition with multifocal, multi-system involvement, and in contrast to Gorham-Stout disease, there is evidence of non-contiguous disease involvement, and GLA can affect the axial and appendicular skeletons equally. The most common sites are thoracic spine, humerus, and scapula, and also in contrast to Gorham-Stout disease and the other conditions we will discuss later, there is no evidence of periosseous or perivascular soft tissue disease. These radiographs demonstrate the most characteristic findings seen in GLA, with well-defined punched-out lesions seen on radiography. These axial CT slices of the chest in a different patient show evidence of well-defined punched-out lesions, again with mild expansion, but no evidence of periosseous or perivascular soft tissue disease. On the MRI, these are seen as well-defined lesions that are T2 hyperintense, and while may cause endosteal scalloping, there is no evidence of active cortical destruction and no evidence of periosseous soft tissue disease. There are, however, systemic findings seen, particularly organ involvement, particularly of the spleen, and this can be associated with macrocystic lymphatic malformation. These images, taken over the course of 7 years, demonstrate the relative stability of the disease, with slight expansion seen within the vertebral bodies, but no evidence again of cortical destruction. This axial MRI slice in a different patient shows almost complete involvement of the vertebral body, including posterior elements, but again with no evidence of perivascular or periosseous soft tissue disease. However, extensive osseous infiltration does lead to weakening of the bone, and compression fractures, as noted here, are commonly seen. CCLA, as the name suggests, is a disease of the central lymphatic channels that may or may not have osseous involvement. A key finding here is the presence of perivascular T2 hyperintense soft tissue in the trunk, reflecting the dilated lymphatic channels. Osseous disease is primarily due to reflux, with focal areas of hyperlucency sometimes seen due to dilated intraosseous channels. And in contrast to GLA, these lesions are much less well defined and can be much more permeative in appearance. This axial CT slice of the chest demonstrates some significant amount of soft tissue disease within the mediastinum. Inferiorly, this can be seen as increased soft tissue disease in the periaortic region. These findings are best appreciated on MRI, with the dilated lymphatic channels manifesting themselves as T2 hyperintense soft tissue disease in the perivascular region. Inferiorly, these continue along the perivascular spaces and can result in reflux into the bone or soft tissues, but on administration of contrast, there is no evidence of enhancement. On radiography, occasional punched out, well-defined lesions are seen, but the most characteristic finding is usually a much less well-defined osseous involvement with almost a permeative appearance to bone, and on occasion, discrete channels can be identified on radiography. These findings are again better appreciated on MRI, with these discrete lymphatic channels extending inferiorly to the metaphysis of the femur in this patient. The lymphatic nature of these channels can be confirmed by direct injection, with contrast seen extending superiorly into the central lymphatic channels. These can be better appreciated on these digital subtracted images, with contrast seen extending into the lymphatic channels in the pelvis, with note is also made of some small lymphovenous anastomoses. The investigation of choice in these patients is lymphangiography, which may be conventional lymphangiography as seen here, or MR lymphangiography. The spectrum of findings is very varied, reflecting the nature of the disease. There may be terminal obstruction of the thoracic duct as seen in this patient, or much more diffuse disease with associated reflux in multiple locations, reflecting a much more functional disorder. The imaging findings in KLA are very similar to CCLA, but with some key differentiating features. As the clinical findings in KLA also overlap with CCLA, the diagnosis is usually established by a combination of clinical, radiologic, and histological findings. A key differentiating factor from CCLA are the presence of thrombocytopenia and hemorrhagic pleural effusions. In KLA, thoracic disease is almost invariably seen, sometimes occurring without abdominal or pelvic findings, which is another differentiating factor from CCLA. The infiltrative soft tissue disease seen in the mediastinum then extends along the bronchovascular bundle, and administration of contrast, here the soft tissue disease enhances, which again is different to that of CCLA. These two axial MRI slices of the chest demonstrate the pertinent findings. There is extensive soft tissue disease extending from the mediastinum along the bronchovascular bundles. Administration of contrast enhances avidly. Note is also made of soft tissue disease in the perivascular region, in the posterior mediastinum, and in the retrocrural region. On HRCT of the chest, these findings are seen as interlobular and intralobular septal thickening. Solid organ involvement can also be seen as in infiltration of the spleen in this patient. Note is also made of heterogeneity of the marrow signal in the spine of this patient. The imaging findings are very similar to CCLA, with evidence of stasis of contrast and reflux. The osseous findings are almost indistinguishable from CCLA, but the vertebral bodies are the most common site, although the axial and appendicular skeleton can be involved. These MRI and plain radiography images demonstrate the T2 hyperintense lesions reflecting the chylous reflux into the long bones, with evidence of channel-like findings within the metaphysis of the femur. These CT axial images of the abdomen also demonstrate soft tissue thickening in the retroperitoneal region and an ill-defined permeative appearance of the underlying vertebral body. So in summary, while these complex lymphatic anomalies have overlapping imaging and clinical features, there are some key differentiating imaging signs. For example, in Gorham-Stout disease, there is definite evidence of progressive osteolysis and enhancing periosseous soft tissue disease. GLA, on the other hand, tend to have well-defined focal lesions, which are much more diffuse in their distribution and affect non-contiguous bones. CCLA and KLA both have perivascular hyperintense tissue, but the mediastinal and lung involvement is much more prominent in KLA, which is also associated with enhancement of the mediastinal and thoracic soft tissue, as well as hemorrhagic effusions and thrombocytopenia. We have used these features to devise a radiology scoring form, which makes it easier to clearly differentiate these conditions. We evaluated this scoring form initially with 2 radiologists from our own institution, and then expanded it to 5 other institutions and 13 additional patients. We found the radiology scoring form to provide a diagnosis that was accurate and reproducible, and the diagnosis was eventually changed in 3 patients out of 29. So in conclusion, there are overlapping clinical and radiologic features in complex lymphatic anomalies, but the use of key differentiating imaging factors improves the accuracy in diagnosis. Thank you.